So back in 2001, the FDA actually had to issue these emergency warning letters to doctors all across the country.
Right, which is never something you want to see.
No, exactly. And the wild thing is, it wasn't because there was some, like, massive manufacturing defect or even wrong
The
dosages.
drugs themselves were completely fine.
Right. It was a wildly popular anti-inflammatory, an antidepressant, and an anti-seizure medication, and they were causing this huge wave of hospitalizations simply because, well, it rhymed.
Which is just terrifying when you think about it.
It really is. So welcome to the Deep Dive. I'm your host, and today we are looking at a stack of foundational texts and safety guidelines to explore these invisible linguistic minefields hiding right inside the medical system.
And I'm your expert for today. Our mission here is to really help you understand how one single wrong vowel can completely change a medical diagnosis.
Yeah, and we want to look at, why these traps exist in the first place and how recognizing them can actually make you a much more empowered, safer patient.
Because the terminology we use to describe this, linguistically, we're talking about paronymy, right? Words that resemble each other in sound but not meaning.
Or homophony, where they're pronounced exactly the same but spelled differently.
Exactly. And in the everyday world, mixing up, say, bear and bear might cause like a momentary confusion in a text message.
Right, it's no big deal.
But in a clinical setting, it alters the fundamental trajectory of patient care.
Wow.
Yeah.
Yeah.
And regulatory bodies actually track this stuff actively. They call it LASA, which stands for look-alike, sound-alike drug names.
Look-alike, sound-alike. Yeah, I was looking at the sheer volume of these ELISA pairs in the source materials, and it made me view medical terminology in a completely different light.
How so?
Well, we tend to think of medical language as this perfectly engineered, highly scientific system, but it actually behaves more like an aging software API.
Oh, that's an interesting way to put it.
Right. Because it's this system built thousands of years ago for a slow-written world of Latin and Greek scholars. And now we're running that exact same system in a high-speed, digital, purely auditory environment.
And the language is crashing.
Exactly. So to understand how these errors happen, we really have to look at the architectural flaws baked into the language itself.
And, the earliest documentation of this systemic failure actually comes from the classroom. It didn't even start in the clinic.
Right, really, just from teaching it.
Yeah. If you look at the traditions of medical textbooks, like the ones by Davy Ellen Chabner or Barbara Jansen Cohen, they dedicated entire sections to commonly confused word pairs.
Huh.
Because instructors were grading anatomy exams and noticing that students were consistently mislabeling completely unrelated body parts.
Just over and over again.
Right. And the issue stems from the modular nature of the language. It relies so heavily on combining specific Greek and Latin roots, prefixes and suffixes.
Which is supposed to make it easier, right? Like playing with a giant bin of Lego blocks.
Exactly. The regularity lets clinicians speak fast. They can compress a super complex concept into one single word.
Yeah, the system teaches you to recognize certain blocks, like the suffix "ium," meaning a tissue or structure, and you just build from there.
But because it pulls from two different ancient languages, Greek and Latin, you occasionally reach into that Lego bin and snap together completely different etymological bricks.
And you accidentally build two pieces that look and sound exactly the same.
Yes. You completely bypass the logic of the system.
Okay, so what's the classic example of that? The source mentioned one that really stuck out to me.
You're probably thinking of the Ileum versus the Ilium. That is the quintessential etymological coincidence.
Yes. Let's break that down because it's wild.
Okay, so Ileum, spelled with an E, refers to the final section of the small intestine. Its name comes from the Greek word ilein, which means to twist or coil.
Which makes sense. It's a highly accurate description of a twisting intestine.
Right. But then you have ilium, spelled with an I. That is the large flaring bone that forms the upper part of your pelvis.
And that comes from Latin. Right?
Exactly. It comes from the Latin word ile, or ilia, denoting the flank or groin region.
So you have two entirely distinct linguistic lineages, separated by hundreds of years, that just happen to converge on the exact same phonetic pronunciation.
I-U-L-E-M.
Wow. And that phonetic convergence creates this immense hazard, especially during verbal handoffs.
Because if a radiologist dictates a note saying mass near the ileum with an E, but the transcriptionist types it with an I,
the clinical picture completely shifts from the digestive system to the skeletal system.
all because of a single keystroke The diagnostic tests, the specialist referrals, they all diverge completely.
Right. But it's not always just a coincidence. Sometimes the danger multiplies when the shared roots themselves create the trap.
Like the perineum and the peritoneum. I was really struck by the frequency of mix-ups between those two. As a perfect example, both of those terms use the prefix peri, meaning around.
Okay, so what is the perineum?
The perineum is the anatomical region between the external genitalia and the anus. You see it a lot in obstetrics or colorectal procedures.
And the peritoneum.
That's the serous membrane that lines the entire abdominal cavity and encases your internal organs.
So they both mean around something, but they are separated by an entire body cavity.
Exactly, and the fallout from that shared root extends way beyond failed exams. Medical safety reports document operative notes where the adjective perineal was accidentally transcribed as peritoneal.
Oh my God. So the official legal and medical record of a surgery describes an intervention in the completely wrong anatomical space.
Which is a massive liability.
Yeah, I'd say so. But you'd think these errors are strictly auditory, right? Like people just mishearing a rushed doctor in a loud hallway.
You would think that, yeah.
But the trap actually extends into written charts through a grammatical loophole. It's not just swapping two body parts.
Right, sometimes it disguises itself as this innocent spelling error that just fundamentally breaks the grammar of a chart.
Yeah, the most persistent example in the source was the difference between mucus and mucus.
Ah, yes. The great noun-adjective divide.
Can you explain that rule? Because I think a lot of people mess this up.
Sure. So mucus, ending in us, is strictly the noun. It's the actual physical, slippery secretion itself.
Okay, got it.
But mucus, ending in ous, is the adjective. It describes the tissue that produces the secretion, like when you say a mucous membrane.
Right, which actually mirrors a broader pattern in English. If you think about the word callus, ending in us, that's the hard skin on your hand, the noun.
Right, exactly.
But callus, ending in ous, is the adjective describing, like, a hardened personality trait.
The mechanics are identical. But there's this huge misconception in clinical charting that mucus and mucus are just interchangeable variants.
Like maybe one is British and one is American or something?
Exactly. But writing a note that says the patient presents with thick mucus, ending in ous, is literally a grammatical impossibility.
Because an adjective cannot possess the physical property of thickness.
Right. It's the equivalent of writing the patient has thick red.
That's hilarious. It just completely strips the sentence of its noun.
It creates a syntactic void. But the phonetic identicality is so deeply ingrained now that linguistic drift is actively happening.
Wait, really? Like the rules are changing?
Yes, some medical style guides have quietly given up enforcing the distinction in casual charting. The sheer volume of the error is actually reshaping the boundaries of clinical language.
That is wild. But okay, so a grammatical void in a chart might annoy a professor or an auditor, and confusing an anatomy term might delay a diagnosis.
Right.
But the stakes really escalate when these sound-alike traps travel from the classroom to the pharmacy.
That is exactly where this shifts from being a quirky language phenomenon to a systemic public health hazard.
Right. I mean, when lives are on the line, how did the medical community finally wake up to this?
It started back in the 1970s. There was this pharmacist named Michael R. Cohen, and he began meticulously tracking and publishing accounts of medication mix-ups.
Mix-ups that people previously just dismissed as like isolated human errors, right?
Exactly. Just bad handwriting or tired nurses.
Yeah.
But he recognized them as systemic vulnerabilities. And his work eventually led to the creation of the Institute for Safe Medication Practices, or ISMP, in 1994.
So they started formalizing the taxonomy of these errors.
Right. They elevated them from anecdotal mistakes to hard, measurable data points.
And that data changed hospital policy completely. By 2001, the Joint Commission made ELASA drug names a national patient safety goal,
Which forced accredited hospitals to maintain and audit their own internal watch lists. Even the FDA restructured its approval process for drug names.
Yeah, they established a whole division just to pre-screen drug names to prevent this.
They do. They run simulation labs. They don't just check a dictionary. They present the proposed name to panels of nurses and doctors under simulated high-stress conditions.
Like with messy handwriting samples and background noise.
Exactly. They literally test whether a new name sounds like an existing drug when someone shouts it down a chaotic hospital hallway.
Wow. Which makes that three-way pileup I mentioned at the beginning, Celebrex, Celexa, and Cerebix, even more baffling.
Yeah, that was a massive failure.
Like, why would pharmaceutical companies ever name drugs so similarly in the first place? Are they just running out of syllables?
It's actually a byproduct of that root-based logic we talked about earlier. Pharmaceutical branding relies heavily on hinting at a drug's mechanism of action.
Oh, right, because they draw from a finite pool of recognizable prefixes and suffixes.
Exactly. The names naturally funnel towards similar phonetic clusters based on chemical structures or targeted receptors.
But Celebrex is an anti-inflammatory, Celexa is an antidepressant, and Cerebix is an anti-seizure drug. They do entirely different things.
They do, but because they all share that hard C sound and similar syllable counts, the brain just groups them together.
Especially when you're reading fast.
Right. The cognitive science of how we read explains this perfectly. We don't read letter by letter. We recognize words by their overall visual shape.
The BOMA shape, I think it's called?
Yes, the BOMA shape. Celebrex, Celexa, and Cerebix share a remarkably similar visual footprint. So when a practitioner is stressed or fatigued, their brain bypasses analytical reading.
They just rely on pattern recognition. The shape is close enough, the sound is close enough, and the error just slips right through.
And that leads to catastrophic outcomes. The source highlighted the confusion between hydroxyzine and hydrolazine, which is a perfect example.
Yes, let's talk about that one. Hydroxyzine is an antihistamine, often used as a sedative.
And hydrolazine is a vasodilator used to rapidly lower dangerously high blood pressure.
So if you mix those up, it's an immediate crisis.
Absolutely. You're either heavily sedating a patient who desperately needs blood pressure management, leaving them vulnerable to a hypertensive emergency,
Or you're artificially tanking the blood pressure of a patient who literally just needed an antihistamine.
which could induce shock.
It's terrifying. There was also chlorpromazine and chlorpropamide.
Right, confusing an older antipsychotic with an oral medication for type 2 diabetes.
Treating a psychiatric condition with a blood sugar drug. It just feels like navigating a minefield blindfolded.
And the visual similarity there, both starting with chlorpro, makes them highly susceptible, especially back when handwritten prescriptions were the norm.
See, that brings me to my next point. My initial thought reading this was, okay, handwritten errors make sense, but modern technology must have solved this by now, right?
You would hope so.
I mean, we live in an era of electronic health records. We have spell check in literally everything. Doesn't a little red squiggly line save the day here?
Oh, I wish. No, relying on standard spell check is actually one of the most dangerous assumptions you can make here.
Really? Why?
Because standard spell check operates on a purely binary dictionary function. It just asks, does this sequence of letters exist in the database?
Oh, I see. Because both words like Ilium and Ilium are valid, correctly spelled medical terms.
Exactly. So the software registers no error.
Error.
It doesn't flag that you just prescribed an anti-seizure medication for a sprained ankle.
Wow, so the tech actually fails us on a semantic level.
Worse than that, it sometimes actively causes the error. EHR autocomplete has been heavily documented as a vector for these mix-ups.
Autocomplete. But wait, isn't that supposed to save time?
It is, but it creates a phenomenon known as premature cognitive closure. It's driven by anchoring bias.
Okay, break that down for me. How does that look in practice?
So, a physician intends to prescribe hydroxyzine. They type HYDR into the search field. The algorithm, which might be sorting alphabetically or by inventory frequency, immediately populates hydrolazine as the first suggestion.
And the physician's brain is anchored by those first few letters.
Right. They're moving fast, so they accept the suggestion without actually verifying the suffix. The technology facilitates the exact cognitive shortcut that causes the mistake.
That is wild. If the underlying software architecture is failing us, what are the actual solutions? Like, how are hospitals fighting back against this?
They rely heavily on a combination of typographic disruption and really rigorous procedural protocols.
Okay, typography. Are we talking about tall man lettering here?
Yes. ISMP championed the adoption of tall man lettering to specifically target that visual word shape recognition we talked about.
So how does that actually work on a cognitive level?
It visually breaks the similarity of the words by capitalizing the syllables that are different.
Okay, so for Celebrex and Celexa?
Celebrex is written with a capital BREX at the end. Celexa is written with a capital XA at the end.
So you're injecting capital letters right into the middle of the word.
Exactly. It destroys that familiar BOMA shape. It introduces cognitive friction.
It forces the brain off of autopilot. You literally can't just glance at the shape anymore. You have to stop and read the capitalized letters.
Right. CeleBRX versus CeleXA. That friction is highly intentional.
That's brilliant. And what about the procedural fixes? Because typography doesn't help if you're talking on the phone.
Exactly. Procedurally, they use something called closed-loop communication.
Closed-loop communication, what does that entail?
It dictates that if a physician issues a verbal order, The receiving nurse or pharmacist must repeat the order back, including the indication, and receive confirmation before they do anything.
Okay, so they'd say, I am preparing to administer hydralazine, the blood pressure medication.
Precisely.
Yeah.
Because verbal handoffs strip away all those visual cues,
Right.
you can't hear tall man lettering.
Right.
So the closed-loop protocol forces the practitioners to verbally confirm the semantic meaning of the drug, not just its phonetic sound.
You know, the lengths to which the system has to go just to prevent these errors, it really brings up this fascinating pedagogical debate within medical education.
It really does. It's this central debate. How do we train the next generation to navigate a system that is basically rigged against them?
Right, because you have route-based instruction on one hand and rote memorization on the other.
And route-based instruction teaching those Greek and Latin origins is highly scalable.
It's the master key to the linguistic API we talked about.
Exactly. If a student understands the foundational prefixes, they can decode thousands of novel terms. But relying solely on that logic has a huge limitation.
Let me guess. The genuine etymological coincidences.
Bingo. When a student encounters the Ilium and the Ilium, the master key fails. The roots are unrelated, but the output is identical.
So in those cases, the logic of the system can't save you.
Right. Rote memorization, flashcards, brute force repetition is literally the only effective defense against those anomalies.
Wow. Which really brings the reality of this entire deep dive squarely back to you, listening right now.
Because all these pedagogical debates and FDA simulation labs might seem like inside baseball, right?
Exactly. But the second you interact with the medical system, this becomes your reality. Anytime medical language travels from mouth to ear, all those visual safety nets are gone.
And your vulnerability really peaks in those auditory environments. Think about a telehealth appointment where the connection is a bit muffled.
Or a 911 dispatch operator relaying symptoms to a paramedic over a crackling radio.
Or even just you, right? Speaking symptoms into a search engine or a diagnostic app, pronunciation is the only signal.
And that's exactly when the trap is set. So as a patient, you have to be your own advocate. You have to actively disrupt that auditory vulnerability.
If you get a verbal diagnosis, ask the doctor to spell it out. If you're handed a prescription, ask them to state the indication, like what the medication is actually intended to treat.
Precision in healthcare isn't just about the science. It's fundamentally about linguistic clarity. You really cannot afford to be passive.
No, you can't. And that vulnerability is only going to evolve as technology changes.
Yeah, that brings us to the final thought we wanted to leave you with today, the whole AI scribe issue.
It's a huge shift. We are rapidly moving toward a future where artificial intelligence programs just listen to the ambient conversation between a doctor and a patient in the exam room.
And then they automatically generate the medical chart based purely on that audio.
Right, so it begs this profound question for the next decade of medical technology.
If humans, with all of our contextual understanding, continually fall for these homophones, how does an auditory AI algorithm distinguish between a twisty intestine and a hip bone without any visual input?
Will the implementation of voice-to-text charting finally eliminate human transcription errors, or will it just trigger a whole new era of invisible, algorithmically generated homophone traps?
Traps that are quietly altering patient charts completely unchecked by human eyes.
It's definitely something to ponder.
We started this deep dive thinking of medical errors like a physical injury, right? Like a broken bone that shows up as a glaring white fracture on an x-ray.
Something obvious that everyone can see.
Exactly. But a sound-alike trap is more like a single misplaced character in a million lines of computer code. It looks perfectly fine on the surface, but it causes the entire program to execute the wrong, potentially fatal command.
The error is totally invisible until the system crashes.
So next time you are navigating your own healthcare, remember that the sound of a diagnosis is not enough. Verify the code. Ask for the spelling.
Keep questioning the systems around you.
Thanks for diving deep with us. We'll see you next time.